Everyone again. My name is Rico Carter. I am AMSA's Community and Public Health Action Committee Chair. Super excited to have you all back this for the second night of National Primary Care Week. We have a really great session tonight speaking about the opioid epidemic, and it's going to be followed by a training. So we have three physicians join us tonight. The first one is Dr. Bruno, and we have Dr. Grover and Dr. Close joining soon. But I'll go ahead and get started with Dr. Bruno. Dr. Richard Bruno, and here's a little bit of his bio. So I'll go ahead and read it out so you know you're speaking with, and then Dr. Bruno, you can take over at that point. Dr. Richard Bruno is a double-boarded family and preventive medicine physician, serving as a senior medical director for primary care at a federally qualified health center that focuses on healthcare for the homeless in Portland, Oregon. He has led workshops, conferences, rallies, and actions for health justice. His main clinical focuses are on HIV, gender-affirming care, obesity, and opioid use disorder, with involvement in community public health interventions and policies, including cooking classes for kids and legislation, expanding across the medication for opioid use disorder. He has served on the boards of the American Academy of Family Physicians, Physicians for a National Health Program, National Physicians Alliance, now Doctors for America, Committee to Protect Medicare, American Association of Public Health Physicians, Physicians for Social Responsibility, Chesapeake Chapter and Oregon Chapter, MedShy, the Maryland State Medical Society, Sugar Free Kids Maryland, Maryland Academy of Neighborhood Association, People's Grocery Co-op, and the Oregon Prescription Drug Affordability Board. He has also served on the ethics panel of the Baltimore City Public Schools District. He attained his bachelor's degree from Princeton University, a doctorate of medicine from Oregon Health and Science University, and a master's of public health from Johns Hopkins Bloomberg School of Public Health. Graduated from the Combined Family and Preventive Medicine Residency Program at MedStar Franklin Square and John Hopkins. He was a candidate for Maryland State Representative. His wife and two children enjoy hiking, biking, cooking, and playing music together. So Dr. Bruno, I'd like to turn it over to you, and thank you so much for speaking again.
Thank you, Rico. Thanks for the kind introduction there. Good evening, everybody. Thanks so much for being on today, and hope you're having a great National Primary Care Week so far. Really excited to talk with you tonight. And Rico, how much time should I allot for this? Just how much should we plan for me to talk for?
I think you have an hour.
Okay. Great. We may not take the whole time, and I'm happy to take questions throughout. If you have questions, feel free to raise your hand, chime in. But I'm going to tell you a little bit about some of what's going on in the opioid crisis right now. I'm sure many of you are very familiar with this, whether you've read books about it, read papers, seen patients, have family members, have friends, have neighbors who are struggling. It affects all of us, right? I don't think I've never met a single person who is like unfamiliar with what's going on with the opioid crisis in this country right now. So I think it really behooves us to really understand some perspective about what's going on, some of the historical context, and also I think what we can do right now to help usher in just a more humane approach to dealing with this crisis. And so I'll go through some slides today, and if you are interested in seeing these slides at any point, the Prezi is online. You can just go to tiny.cc/opioids-amsa and see those slides. But what I'm going to do today is first kind of just do a little quick disclosure. I don't have any financial stake in any of the companies or organizations or medications I'm going to be talking about today. And I also want to dedicate this talk to a patient of mine, Theodore Williams, who I lost last year to opioids. He had struggled with it most of his life, and he's somebody that I met very first month of my residency training in 2013 in Baltimore, and became one of my favorite patients. He's just a really amazing guy, and he struggled in and out with substance use, and he was actually working on trying to get his master's of social work to be a counselor, to try and help other people, be a peer for substance use, and unfortunately succumbed to the disease. And went to his funeral and spoke with his friends and his family, and just someone I cared deeply about, and somebody who I was very sad to lose. But in honor of him, I want to just dedicate this talk to him, and I hope that as you're going through these trainings, you find those meaningful, whether it's medical school and beyond, that you find patients that you're able to connect to and hold close to your heart. So let's start a little bit with objectives tonight. And I really just want to help people understand the impact of opioids on our society, appreciate the human face of addiction, recognize the dangers to patients and communities, and identify the role of advocating for better policies and really curbing this epidemic. So let's start off with the problem. We know that increased opioid use is really and deaths have really increased over the last 20 years, but by how much? I mean, we can look at these graphs from CDC. We can see certain drugs definitely more deadly. The yellow line there is methadone. Doesn't tend to be super dangerous compared to the orange line of heroin, for example, which really kind of increased a lot by 2016, but has kind of leveled off. And I want you to look at that light blue line. We're going to spend a lot of time talking about that one today. That's other synthetic opioids. It includes drugs like tramadol, but it's mostly the fentanyl that we're going to be talking about today. And I'm sure you've seen or heard about the fentanyl epidemic sort of emerging, one of the most dangerous pieces of this opioid crisis. So let's talk about opioids and opium. We have a timeline here. Poppy plants have been scored to collect opium for a long, long time, many millennia. But really by 1806 is when morphine was first isolated from opium. By 1843, the hypodermic needle was invented. And in a tragic irony, the inventor's wife, Rebecca Massey, became the first person to die from injecting. By 1874, heroin was synthesized, initially as a non-habit producing alternative to combat the opium dependence, but we actually found out it's about 10 times more potent. And then dozens of opioids have been synthesized since, codeine, fentanyl, hydrocodone, hydromorphone, or Dilaudid. We have methadone, oxycodone, Oxycontin, tramadol. And by 1961, the antidote, naloxone, was first synthesized by Jack Fishman. And another very tragic piece of irony here, his son Jonathan overdosed on heroin and died without the antidote. Very sad and tragic timeline here. Picture of a painting of an opium den in the Ming Dynasty. And so we have a number of policy failures as well. So I'll start with this one. We have, as we were starting to understand the increased demand and the ignored dangers, things began to kind of spiral out of control. And one of the sort of linchpins in this was an FDA reviewer, Curtis Wright, who had co-drafted an FDA review of OxyContin with a Purdue employee in 1995. And he allowed the package insert on OxyContin to assert that delayed absorption reduces abuse liability. And so he basically gave a rubber stamp to OxyContin to be approved by the FDA because the delayed release formulation was considered to be less dangerous. So we'll talk a little bit more about that. There's also some frameworks in place that have been set in by the American Pain Society that, pain is the fifth vital sign. We should be asking about your pain level every time you come to the doctor. We should check your blood pressure and your temperature and everything, but also ask about pain, right? So we constantly ask about pain, document the pain score 1 to 10, and treat the pain. Another really important piece in all this was this misconception that opioid addiction is rare in pain patients. So this was really promoted by this poster child of a letter to the editor in the New England Journal by Porter and Jick on hospitalized patients in 1980. They had written a letter. It was just a 5-sentence letter, right? And they had noticed that patients who were being discharged from the hospital, they followed up with a phone call a week or two later and asked, are you having any withdrawal symptoms at being off of the opioids that we prescribed for you while you were in the hospital? And they had this figure, it was like less than 1%. From a few phone calls, they came up with this statistics, less than 1% of people got addicted to pain medicine, right? And so this less than 1% was a mantra that the pharmaceutical company used and pushed and pushed and pushed and quoted and quoted and quoted. This one wasn't even a peer-reviewed study, right? It was simply a letter to the editor. But unfortunately, it was taken way out of control. So, Purdue Pharmaceuticals introduced in 1996 OxyContin, and 5 years later, they had spent $30 million a year on advertising, and resulting in $1.3 billion That's a billion with a B. So you can see the sales just going up and up and up. Number of prescriptions going up and up and up. And so you can see they spend a lot of money promoting this, to patients, to doctors and prescribers and providers, and just basically anyone that they could. They made these little videos where they would have these testimonials from people saying, OxyContin changed my life. I can finally, go out and go for a walk with my family, kind of a thing. I got my life back was the name of the marketing video, and they would drop off these VHS tapes, at doctors' offices so they could see what it's like, from these patients' perspectives. But by 2007, after recognizing, not only sort of legislators and governmental officials recognizing that we're really doing ourselves a disservice, this is causing a lot of harm in society. By 2007, the trial came out. 3 senior Purdue executives pleaded guilty, federal criminal charges. They had misled regulators, doctors, and patients about the risk of addiction associated with the drug, and they paid $600 million in civil and criminal penalties, which we know is just pocket change compared to the money that they were making in the billions. There's a great documentary on this if you want to check it out on HBO called Crime of the Century, a 4-hour documentary. Really goes into details with all the people who are affected, individual patients, doctors, regulators, and they document a lot of this in a really interesting format. So around that time, there was this effort to try and make things a little safer. So they came up with an abuse deterrent formulation of OxyContin. So it was basically, as you can see there in the bottom left, originally you could sort of crush up the OxyContin. You could mix up the powder in some water. You could draw it up in a syringe and inject it, right? But this abuse deterrent formulation, basically, you couldn't really crush it very well. It kind of gummed up or gelled up if you tried to add water or tried to make it into a liquid that you could inject in your veins. And so it made it so that you couldn't really inject. So what happened then was that, as you can see in the bottom right here, is that around that time that abuse deterrent formulation was released, you started to see a spike in heroin use. So people were returning to heroin instead of oxycodone, OxyContin. And so the numbers started to spike here. And you can see the number of deaths from heroin really started increasing around the time of that orange arrow, around 2010. And that really kind of models this as well. So even though that orange line there, the heroin really started spiking around then, even stronger drug called heroin or fentanyl, which is somewhere around 50 to 100 times stronger than morphine, starts being introduced into the drug supply. And then what we started to see is that, people who typically would use heroin were also coming up positive for fentanyl in their urines. People who typically only smoke marijuana were having fentanyl in their urine, right? And so it was starting to cause a little concern in the medical community. It's like, what's going on? Why are people getting really heavily affected by these meds? And we started to recognize that fentanyl was being tainted or adulterated into other drugs on the street. And so this happened over a number of years. And then, in fact, here in Portland, Oregon, these days, it's very hard to find heroin at all. According to my patients, they say that fentanyl, specifically fentanyl pills, these little blue pills that have a number 30 stamped on them, which is basically pure fentanyl, are basically the kind of the going rate on the street these days. So people get the blues from the street. They're about $5 a pill, and a lot of people are freebasing them and just put it on some foil and light it up and kind of breathe the fumes, and it gets you very high very quickly. But that high, of course, kind of runs out very quickly as well, and so people are hooked pretty fast and end up, buying multiple pills a day. I have one patient on 30 fentanyl pills a day. So some pretty heavy use and pretty difficult for folks to deal with. On the East Coast, we're starting to see a lot more fentanyl powder out there rather than pills. And sometimes that powder is snorted. Sometimes it's made into a liquid that can be injected as well. So, some very dangerous uses of fentanyl out there these days, and very concerning for obvious reasons. So that's kind of the trajectory to today. But I want to give you some tips on how to sort of think through this a little bit. And before we kind of get to like how we're going to address the opioid crisis, I'll take any questions if anybody has any thoughts, or I don't know if we have a chat going too, Rico. We could. We got some people in the chat. Sorry, I haven't been looking at the chat, but anything in there that I should take a look at? Any questions so far? Okay. Great.
Yeah,
so
please feel free to drop them. Sorry.
Yeah, how's this landing with folks? Is this something that you see happening in your communities?
I mean, I know here in Tampa, it's not like extremely like how you described it in Oregon, but it's still pretty prevalent, unfortunately. But we do have a question, it looks like from Evan, that says, why is fentanyl found in different forms based on domestic location?
Yeah, really great question, Evan. My guess is that different drug trades, different drug trafficking happens at different ports or in different regions. So, a lot of times we know from the West Coast, a lot of the fentanyl that's coming here is made in China and shipped over. We know that a lot of the heroin that was coming through sort of Midwestern states and East Coast was coming from Mexico. It's just sort of regional variations and differences in like sort of how it's created, shipped, trafficked, and distributed along different cartels, different criminal rings. Yeah, I'm not in law enforcement, so it's hard for me to know exactly, but that's my best guess.
Dr. Bruno, I got one question, and I'll let you continue to. So I guess I was kind of under the impression too, like learning about these things that at least beforehand, and it seems like it's more of a street. Is the dependency on these the drug use based from physician administration, or like with the Oxycontin and the other opioids? Do you think that addiction to those street drugs are leading to was it stems from that originally? Because I think that's what I've always been taught. I don't know if that's the case.
Yeah, I'm hearing that too, Rico. From my patients, some people get into it because they broke their leg in high school, right? And they got some oxycodone from that, and they just kind of like, they were really sensitive to that, really susceptible to that, and really kind of got into using more and more, trying to get more oxycodone. When they couldn't get oxycodone, they switched to heroin. When they couldn't get heroin anymore, now they're on fentanyl. So it's just sort of like, one thing leads to another. And if we can't interrupt that cycle, which I'm going to talk about in a minute, can, obviously lead people to lose their lives. So it can be very, very dangerous for so many folks. Yep. Looks like someone's asking about Narcan in a few minutes. Definitely Narcan is a very important antidote to help prevent people from dying when they're overdosing. Marcella says that she's heard about other street drugs being laced with fentanyl. Yep, we're seeing that too. Yep, I had a patient in Baltimore who her sister died of fentanyl overdose from simply smoking marijuana that had been laced with fentanyl. She had no idea that it was being laced. Yep, very unfortunate. Yuri's asking why some people are more susceptible to becoming addicts. I've known others to take oxys that are not addicts. Yeah. So one of the things I wanted to also get across in this talk is helping get our vernacular and the way we describe and talk about people to be very non-judgmental. So I try not to use the term addict. I think it's one of the words that can be a little stigmatizing for folks. So I'll just say somebody who uses drugs, somebody who injects drugs, a person who has substance use disorder, a person who has opioid use disorder. I'll talk about what meets those criteria in a second. But some people just have a greater susceptibility, whether it's genetic, whether it's behavioral. Some people just are just way more susceptible to this than others. Some people can take a bunch of oxycodone for a toothache and be fine, and not have that pull to want to use anymore. And some people, it really hits them hard. Oh, great. Thanks, Michael, for sharing a way to get some Narcan. Well, let's switch gears a little bit. Let's talk a little bit about what meets those criteria for opioid use disorder. Let's talk through that a little bit. So, for folks in addiction medicine, we use the term dependence and addiction, and they're slightly different. Really, someone who's dependent on something really is manifested by going through withdrawals when they stop using. It's really an expected consequence of having chronic opioid use. Addiction is really having multiple factors influence someone's behaviors to want to use. And so oftentimes it's characterized by having impaired control over drug use, either compulsive use, continued use despite harm, and cravings to use. And we have the DSM-5 criteria here for substance use disorder. Really, it's using in larger amounts, wanting to cut down, but not being able to, spending a lot of time trying to acquire the drug, having those cravings, unable to manage commitments, and, it's impairing other parts of your life, relationships, activities, something that puts you in danger. So if you have, severe disorder with having 6 or more of these. Thanks. And so we can compare opioids. Really, we have about there's about 2 million folks on prescription opioids, compared to about 16 million folks with alcohol use disorder in the country, and about 46 million folks with the tobacco use disorder. And we can kind of look at the total deaths per year. Obviously, opioids around 33,000, alcohol around 88,000, tobacco around 439,000 total deaths per year. And so kind of puts it in perspective, I think, to compare opioids with alcohol and tobacco in this respect, especially in regards to the overall societal cost there. Obviously, it's huge. I have a little bit more details on sort of the receptors that are involved, so the medications, things like that. Feel free to look through this. I'll make these slides available. It's also available in a link, and I'll put it in the chat as well, because I think someone asked a little earlier. So you can check out these slides at any point. So my main thesis with this talk really is to talk about where we can have interventions along the way of people who are getting addicted. And some people we know are more susceptible to being addicted. You've heard the old analogy about seeing the person who falls in the stream, and you have these people trying to rescue and pull people out of the stream. And one guy's like, well, why don't we just go upstream, right? So this upstream mentality is really what this is based on. And I also stole an analogy from Dr. Camara Jones, who was the president of American Public Health Association a few years ago. She gave us a talk about the cliff, falling off the cliff, and we want to save people and go up and prevent people from falling off the cliff. So I kind of combined those two metaphors, and I called it the waterfall of addiction, right? Because we want to prevent people from falling in that waterfall of addiction, getting addicted in the first place, falling off the waterfall and overdosing and dying at the bottom of the waterfall. So at all 3 levels, we can find ways of preventing people from dying. And you can kind of think about it in preventive medicine, we call it primary, secondary, and tertiary prevention, right? So we want to prevent people from getting the disease in the first place, prevent them from falling in that river of addiction, go way upstream. And that's way, the ways of doing that are really to prevent the flow of those drugs into our borders, prevent the fentanyl from coming in. And it's really impinging on law enforcement and to really help with these issues. Another way we can really decrease inappropriate prescribing of opioids. The CDC has done a good job of really trying to help providers be very considerate about prescribing long doses of opioids. Usually for something acute like breaking your arm, 7 to 10 days. if appropriate. And so giving some guidelines around that is really helpful for providers, prescribers. I think it's, we don't address a lot of people's underlying trauma. A lot of people are sort of self-medicating because of underlying trauma or mental illness that they really are not dealing with in other ways, more healthy ways. And so I think making sure we have enough mental health providers, social workers, counselors in our communities is also a really important step. We're tragically behind on the mental health side as well. Another way is really to increase coverage of non-opioid pain therapies. I tell you, I can prescribe medications that are lidocaine patches or diclofenac gel, or things that can help my patients with their pain, but oftentimes they aren't covered by insurance, right? So if the insurance isn't going to cover it, it's very difficult for people to get these medicines that they would need. It's easier for me to write a prescription for oxycodone, right? Because oxycodone is usually covered by most insurances. I can write the prescription for that, but if I have to kind of get them a non-opioid therapy, it's not always covered. So that's a difficulty inherent in the system there. Or I have to do a prior authorization or things like that take a long time, and my patients can't wait sometimes. Reducing stigma, making sure we're providing trauma-informed care, increasing human connections. All of these really help support people, and I think especially when it comes to addressing underlying trauma, these are things we can do to help people from falling in that river of addiction in the first place. Midstream, we want to erect a net right at the top of the waterfall. We want to prevent people from falling over that waterfall. So we need to catch them before they fall, right? And those midstream is where I do a lot of work. So somebody's already kind of fallen in, they're already struggling with addiction. How can we get people access to medication for opioid disorder? This is MOUD, formerly known as MAT, medication-assisted therapy. This is often Suboxone, methadone, Vivitrol. These are medications that help people not use. And so I'll talk a little bit about those in a minute too. Needle exchanges are a great way to prevent further disease, right? We can get people clean needles if they're going to inject. Clean needles help prevent the spread of HIV, hepatitis C, prevent bacterial infections, endocarditis, abscesses. Really important. Overdose prevention sites is a really hot topic right now, and some of you may have seen some of the work that's being done in New York, Philadelphia. If anybody here is from Vancouver, British Columbia, these are places where people can go, do what they're going to do. They have access to clean paraphernalia, but it's in a supervised situation where they have a doctor and a nurse on staff. So they do what they're going to do, inject or whatever. As they're leaving, they hit them with the social services and they say, come back tomorrow. We'll get you into detox. We'll help you with your medication, what you need. And that sort of open door policy, I think, is a really, really helpful harm reduction strategy, because nobody dies or overdoses in these facilities. In fact, I've never heard of a single person overdosing because they're in a supervised facility. So really it's just overcoming a lot of stigma, and that stigma often comes from elected officials who don't understand the benefit. But I'll talk a little bit about those in a minute too. One thing I also wanted to get today was point of care fentanyl testing, right? Because we know that some people are scared of using drugs that may be laced with fentanyl, so they may want to test their drug supply to see if there's fentanyl in it before they use. So let's talk a little about that for a second. These are some kits that we give out at my clinic. So it includes those little bullets of sterile water, and they're blue, a little cooker there, or a little thimble for them to kind of put a little sample of whatever the drug they're going to be using with some water. And then it has these fentanyl strips in here. And so what it does, people can take the strip and dip it into the water that has whatever drug they're doing. Let's say heroin, for example. And you dip it in there. And when you get the result, 2 lines means there's no fentanyl. 1 line means there is fentanyl, which is opposite of a COVID test, opposite of a pregnancy test. I always have to counsel people and remind them about that. But if there's fentanyl and they don't want to be using fentanyl, don't use it. If there is fentanyl, or if there's no fentanyl and they're going to go ahead and use it, just do it in a safe way. And we talk about going slow, don't use alone, and make sure you call somebody or have Narcan nearby in case you overdose. So this is one great way we've been working on trying to ensure that people are using safely. And fentanyl test strips are something that you can get at your clinics, get at your schools, and something to think about in a very harm reduction fashion. I did want to get to, at the bottom of the waterfall. Let's say somebody has overdose, right? And they're drowning at the bottom of the waterfall. We want to save their life, but we want to give them Narcan, right? That's the antidote that can reverse the overdose and bring them back. But it really is a life preserver that's made out of paper, right? Because it's going to dissolve in 15 minutes. So we can do our best to really save their life in the moment. But I think, so it's necessary, but not sufficient, right? We really have to work upstream, go upstream and prevent those things further upstream so that we're not having to, work so downstream and try and save people's lives with our limited supply of Narcan that's out there. So let's talk about Narcan and naloxone in a second. First, I want to talk about prison and folks who are returning citizens, because we know that a lot of folks get locked up, they go to jail, they get convicted of drug crimes, they go into jail. A lot of them have drug substance use disorders themselves. In fact, about over half of state inmates and about and a little less than half of federal inmates have a substance use disorder, but very few of them actually get drug treatment, and that's Suboxone, methadone, etc. So unfortunately, a lot of people who go into prison are forced to go into withdrawals, and it's be very, very painful, very difficult for them. We know that people on the jobs who are trying to maintain and some people are using drugs while they're trying to do their job. Some people are able to do that well, some people aren't. But we know that employers that offer drug treatment show much better retaining of employees. We know that the return on investment is about $1,500 for every employee that undergoes the 60 days of treatment, and it leads to less absenteeism, tardiness, conflicts, and productivity loss. So, I've worked with organizations where we're trying to promote that employers allow and give opportunities for employees to get that drug treatment that they need. Here's an example of one of those overdose prevention sites I mentioned earlier. This is the one in Vancouver, BC, called Insight. We went here on an AMSA trip in 2012, and we went to the site as part of an excursion between Seattle and Vancouver, and got to visit this site. It was very impressive. And you can see the stalls there. People come in, they get their paraphernalia they use, and then on the way out, they get information about detox and other options there. Another great, very forward-thinking organization at the Baltimore City Health Department does these needle exchange vans. They drive all over town. Every day they're out there. People can bring their old needles and exchange them for clean needles. They also get Hep C and hepatitis B, C, and HIV testing as well. And let's talk a little bit more about Narcan, because I think this is a really, really important aspect and something that I recommend carrying with you wherever you go. I keep my Narcan in my bag so that if I ever see somebody who's out and not responsive and I think may have overdosed, then I'll have it right there ready just in case. So naloxone comes in many forms. Narcan is one of those. The spray is sort of the name brand, but you can get naloxone as an injectable. There's in the bottom right, there's like a spray, little atomizer that you can place in the nose and just kind of spray it up the nose. There's the really fancy auto injectors that talk to you and they tell you place against patient's leg, and you hold it and it says push button now, kind of like a defibrillator or an AED device would. Those are nice, the Evzio brand. In the middle there, you can see there's an app that allows you to do in sort of an Uber-like fashion, to be able to respond to local requests for Narcan or naloxone that you may be closer than an ambulance would be. And so it would alert you as to know if somebody in your area is down, that you could go and respond if you have Narcan on you and go and do a resuscitation. So pretty cool stuff. So how do you get Narcan? Well, first you want to make sure that you are doing it to the right person, right? You want to make sure that somebody who you see who is down is actually having an overdose of opioids. And it can be hard to tell, but you really want to make sure that they meet certain criteria, right? You know, if you suspect that, you know, somebody that you know who's using, you know, it's probably a good sign. But other things that you can do, you know, you can, if they're not responding, but you can look at their pupils and, you know, pinpoint pupils are usually a sign. Blue lips, slow or no breathing. You know, these are signs that it's probably more closer to an opioid overdose. And so what you want to do is sort of try to arouse them, right? You know, shout at them first. Hey, you doing okay, buddy? Come on, wake up, wake up. I'm gonna Narcan you, right? If they're not responding, you can shake their shoulders a little bit, kind of like, you know, try and rouse them up. And then try and do a sternal rub or pinch their fingernails, you know, just something painful, trying to arouse them. And if you're still not getting anywhere, go ahead and break out your Narcan. And you want to put the Narcan right up in someone's nose, and squirt it. For these, you can do half in one side, half in the other, or you can just do it all in one side. And what you'll want to do is, you know, it usually, if it's going to work, it usually reacts pretty quickly. You can sometimes wait to see if it's having any kind of response. Sometimes, because of the fentanyl is very strong, it may require multiple doses of this. You know, we have a policy at our organization is you know, we find somebody who's down, maybe was using the bathroom and they're not responding. We'll do 2 or 3 of the Narcan nasal sprays first, and if we're not getting a response, we can move to the injectable Narcan, the injectable naloxone. And sometimes we've been seeing that we need more and more naloxone these days to get people aroused and back. Obviously, if somebody's not breathing, you can do some rescue breaths. If they don't have a pulse, go ahead and start CPR, and try and get somebody to call 911 while you're working on all this. I was going to show a video of The Wire, which is a show about the Baltimore drug scene from the early 2000s. This is a really great episode where Waylon is at he's at an NA meeting. He's just talking about his addiction and like how difficult it's been for him. Tells a great story about growing up with this addiction. But I think for the purposes of today and our time limits, I'll save this, but go back and watch this sometime. You know, you can always watch it through these slides. I think it's really interesting and a really great story. We talked a little bit about people who are, you know, going into prison with substance use disorder, but I didn't talk about people as they come out. And so one of the things I wanted to mention, because I think it's really important to think about this, is that people who are recently returning citizens will sometimes start to go back to old habits and return to use. And oftentimes they'll use at the same dose that they were on before they went to prison, but they don't have a tolerance built up. So oftentimes that leads to overdose. And so it's a very dangerous situation to be in, to come out of prison and return to use again. So there's a lot of efforts at play. There's an organization in Baltimore, for example, that waits outside of the jails, and if people want to get into drug treatment right there, they can help them out with that. But really, people should be able to get access to substance use treatment while they're in prison, right? And so this is something that Rhode Island led the way in. A few years ago, they implemented a Suboxone program within the jail, and they decreased the post-incarceration overdose deaths by 12% in the first year that they had this program. So I think these are the kinds of things where if we can get people the right treatment at the right time, in the right place, then this is something that I think we can do to help save lives. This is also a really great book. It's called Dreamland by Sam Quinones. Came out in 2015. He masterfully weaves this narrative of drug cartel folks, where they're growing the opium, growing the heroin in Western Mexico, and how the channels kind of go throughout the United States. He talks about Purdue pharmaceutical executives. He basically interviews and has these incredible story about how all of these different folks aligned, and how the DEA and law enforcement was kept in the dark for years. Right. So what we saw 2007 to 2013 is that heroin started kind of flooding through the states, right? Kind of started on the West Coast and made its way through middle America into the East Coast. And really interesting because what happened was they were targeting a lot of folks at methadone clinics. So one example that Sam Quinones writes about in his book is you had these guys who would stand outside of methadone clinics and hand out business cards with a phone number on it and say, hey, we can get you some cheap heroin if you want to call this number. So you call the number and it's a guy sitting in a hotel room, picks up and he says, yeah, okay, meet my driver. He text pages the driver where to meet this person. The driver simply has a bunch of balloons of heroin in his cheek like a chipmunk. And he just drives around town and people get in the car, he sells them the heroin and they leave. He doesn't have a firearm. He doesn't have anything that would be a felony otherwise. And because a lot of these guys were coming from Mexico, they weren't citizens, they were simply deported if they got caught. And so they would just get replaced by another guy. And so they had this going on for years and years and years, this exact same model just across the United States. And it worked really well to get heroin into the communities. So let's talk a little bit about some of the things that are working, different models around the country. But first, I just wanted to check on any other comments or questions here in the chat. Rico, anything coming up I should take a look at? Any questions here?
There were a few. I think the first one, I'm not sure I pronounced names, so sorry if I butchered. I think it's Zanib or Zanab. Said, I've been hearing a lot about fentanyl being used in trafficking as well. What are the signs? What are the signs if someone has been exposed to fentanyl?
Yeah, great question, Zanab. This is something that I think, fentanyl is like a very, very strong, very potent opioid. So you're going to see effects that are similar to other opioids, oxycodone, heroin, but just much more severe, right? So oftentimes we'll see people, especially if they're using outside on the street, oftentimes in Portland, people are kind of sitting down on the curb and it'll hit them very quickly. And they'll just, I imagine it feels very good to get that sort of rush that you get, very calming, and very sedating kind of at the same time. So people often get very, very quickly sedated. Like I said earlier, pinpoint pupils, decreased respirations, lips starting to turn blue or pale. These are very common signs.
Thank you. And then we had another one. Where you still just wanted to do questions?
Yeah, let's take another question or two. Yeah.
So Evan said, what about hotspots, uneven distribution of fentanyl? Is there any real way to combat that? Seems to be more risk than reward.
Yeah. So are you talking about hotspots in the country? Like different levels of fentanyl in different parts of the US? I've seen, hotspots and drugs being laced. Okay. You're talking about the actual drug itself? Yeah, so there's something called the chocolate chip effect, right? Because oftentimes it's an uneven distribution of if something's laced. So let's say you have a gram of heroin and part of it may be laced with fentanyl, but the other part might not. So yeah, it's a difficult thing. We warn people about that when we give them the fentanyl test strips, is that sometimes it may be an uneven distribution. And so, we say just take a small piece. And, you just kind of hope that you don't, that you do get the chocolate chip if it's in there, right? That being the fentanyl. So yeah, it's not a perfect science for sure.
Then we also have, is there a lot of pushback? I'm not sure what POC stands for, but POC fentanyl testing.
Oh, point of care. Yep. It's actually, having those fentanyl testing strips. Well, so one of the problems is, Marcella, is that it's not a CLIA approved strip. So we give them to patients to test their own supply, but we don't use them as a clinical diagnostic in the clinic because it's not authorized for that. So we'll either give people the fentanyl test strips and they can use it themselves on their supply or their urine. It works also in urine. So someone can pee and see if there's fentanyl in their urine to see if they've actually been using it or not, if they're worried about that. And so sometimes they'll just tell us the results of that, and we can either document it or put it in the chart and say that this is what the patient reported, but this is not something that we administered. So it's an important distinction there. And I think that's where some of the pushback is coming from right now. Okay, great Questions. Keep them coming. I'm going to go on to really quickly, like just a few things that from some recent reports. So the Agency for Health Research and Quality, AHRQ, had to put a report out in 2016, talked about MOUD in primary care, and they recommended and documented about one particular method of education called Project ECHO. Some of you may have heard of this. Really, it's kind of a hub and spoke model. So you have sort of a central university or hospital that acts as a hub, and then you have spokes out to different community sites, different community health centers or federally qualified health centers or clinics in the area. And it acts as like a sort of a weekly meeting. People come together, ask questions of experts, and get sort of like ongoing education about addiction. So Project ECHO, it's a great format. Surgeon General's report that came out in 2016. CDC has also put out these guidelines. I mentioned this earlier, talking about those non-opioid therapies and getting people access to MOUD, all very important. Surgeon General's report, they talk about prevalence and demographics of folks who are using, and they had 42 evidence prevention models that are pretty powerful and things that are working around town and around the country. Workplace models are also really effective. I work here at Central City Concern in Portland, so we have workplace models where we get people into housing first, and then also get them access to jobs, job training, and job advancement throughout the organization. About 40% of all of our employees are former users and in recovery. And so I think it's a testament to the fact that we are supportive and sort of in that recovery environment. Your coworkers oftentimes also in recovery. So it's also really helpful for people to have that support at work. Another great model is the Therapeutic Workplace in Baltimore. At Johns Hopkins, they have a model where they pay people for having urines that don't have drugs in them. So, they have, clerical jobs and their pay rate sort of goes up and up the more it's called the contingency model, contingent on that urine not having substances in them. There's IOM report in 2013 about substance use in the armed forces. I think there's a few more I wanted to go through really quick. Oh yeah, Baltimore City had an overdose prevention program where they distributed naloxone kits to multiple places around the city, and they showed that we were able to train thousands and thousands of people how to use Narcan. They also had a standing order for Narcan, so you could go to any pharmacy and get Narcan without a prescription, which was also reducing a lot of barriers. and they showed a lot of reversals from those trainings, which was great. So I want to kind of recap really quick. I'm hoping that this kind of helps change your mindset a little bit about addiction as a disease, and that people do deserve compassion. We really want to pass policies that work, not punish, and we really want people to work together across different agencies, across different sectors in society, to help ensure that we're working on these things together. Some recent changes, if you're interested in becoming a Suboxone prescriber or for buprenorphine, you have to have a certain waiver from the government, from the DEA, and you have to have shown that you've done certain X number of hours of training in order to get that waiver. It doesn't exist for any other medications that we prescribe, which is kind of interesting. But there's been movement on the federal level to reduce or remove those certification requirements, that people can be able to prescribe this medicine without having to do the 8 hours of training that I had to do. And we've seen that, in France, for example, when they reduced the waivers, that more people got buprenorphine. And so that was really helpful. Use your voice, be an ally for your patients. Tell those stories that you're having, that you're seeing in your clinics, in your hospitals. Write an op-ed, write a letter to the editor. Talk to your officials and your elected officials about the patients that are their constituents and your patients, because you need to work together to be able to solve these problems on a larger scale. These are just some examples of some op-eds I've written recently, trying to make sure that we are doing the best we can to spread the word. So yeah, I'll leave a couple of minutes for questions. Again, you can see these slides anytime by going to that website address there. And yeah, any further thoughts? Love to hear from you.
I know there was one that asked, what was the name of the app where people can respond to different overdoses?
Yeah. So there's a few of them. Let me see if I have one pulled up on my. So let's see. One is called Opioid Rescue, like Opioid Rescue. That one can help you recognize or be able to respond for people's requests. There was one called Naloxone Finder, is another one. Pulse Point is tied in with local 911 jurisdictions, so you can see all the 911 calls that are coming through. And if there's a request for opioid reversal, you can respond to those pretty quickly. Pulse Point's probably the largest of these. But yeah, and check it out. I mean, there's probably even more since I've looked.
Well, I know we're getting close to time. Bruno, we still have 2 more speakers coming on, just so everyone knows. We still have to have the actual Narcan training coming up soon, so please don't log off. But Dr. Bruno, it was a really great presentation. I can't thank you enough. Very informative. Is there any way that do you mind if I share your email in case people have follow-up questions to send?
Yeah. I'll put it in the chat, and feel free to email me if you have further questions. Happy to help. Just let me know. Keep up the great work. Be an ally for your patients. Just keep learning more and more about how to serve your community better. And yeah, good luck through your trainings. And thanks so much for the invitation. It's been a real pleasure. Thanks, Rico.
Absolutely. Thank you so much, Dr. Bruno.
Thanks, Pete. Thanks, Michael.
All right. So everyone, looks like we have Dr. Close here with us. And Casey Grover. Okay, Dr. Grover, got you. So it looks like everyone's here. So sorry about that. Thank you both for joining us. So we just had a presentation on the opioid epidemic and how it's really affecting everyone in America, and then also some public health preventative measures and stuff. And so really would like to thank you both for joining us. And I will introduce both of you all by reading the bio that I received. And can take it from there. And so Dr. Casey Grover and Dr. Reb Close are both emergency physicians at the Hospital of Monterey, Peninsula, and are also board eligible in addiction medicine. Dr. Close and Grover are the physician leaders of the Monterey County Prescribed Safe Initiative, which is a collaborative effort established in 2014 in response to prescription drug addiction and deaths from drug overdoses in Monterey County. It has evolved to address the current drug misuse trends, community prevention, and addiction treatment efforts. So we'd love to turn it over to you both. And again, thank you so much for joining us.
Well, thank you. It's a pleasure to be here. Thank you so much for having us. As a quick introduction, my name is Reb Close. Since both of our names are pretty androgynous, we try to clarify pretty early. So I'm Reb, and this is Casey, and thank you for having us. All right, so let's go ahead and get started.
You haven't shared your screen yet.
I'm working on the screen share.
There we go.
Oh, no, not a chance. Not everybody has this skill set. Okay. Can you see the screen? And my goal is that it's actually, is it in presentation mode, I hope?
Yep, it looks good.
We
Okay.
can't see it.
Yep.
All right. So again, yes, my name's Casey. Reb, just as a disclosure, we're married. We're in our den. So if we have, it seems like there's inside jokes, it's because there are. Just want to say thank you to Michael Walls. He rotated with us. Michael, I think it was, oh gosh, it was almost a year ago. It was last summer. Just thank you for thinking of us. We're very passionate about this work, about addiction. We both work at our local syringe exchange. We can talk about harm reduction. We can talk about kind of the finesse of a naloxone save to make it as uncomfortable for your patients as possible. And from an emergency medicine perspective, both of us have given naloxone, you know how many times, and then it's changed as we've learned addiction medicine. So it'll be kind of a nice hybrid of both perspectives.
Yeah, so what is naloxone, right? And I know you guys are familiar with this, but it's the medication, and we describe it as the antidote in an opiate overdose. And so, you know, and I show this to my patients all the time. You've got opiates sitting on the receptor, and what naloxone does is it comes over to that receptor, pulls off whatever opiate it is, and then binds, but it binds it without activating it. So it's like a dummy key, right? You put the key in, it blocks the lock, but doesn't open the door. So it's kind of the same thing. And that's how we describe it when we're describing it to our patients. And I know you guys are already familiar with it. So we'll move forward. Are you guys, I don't know what just happened. Are you guys,
Weird.
that was really weird. Are you guys hearing anything weird, or was it just us? No, we're good.
So now you all are muted, but I didn't hear anything on my end.
Okay.
There was
Go ahead.
something playing in the background. Sorry. Okay. So as you guys know this as well, things that cause an opioid overdose, you know, everybody thinks of heroin. Obviously, we're now thinking of fentanyl, hydrocodone, you've got codeine, you've got dilaudid. We can move through these pretty quickly, as you guys, again, are familiar with this. But all of these, the fortunate thing is that all of these are reversed in the same way with naloxone. And now I can't get the slides to go forward. I don't know why this is fighting. Okay, so can you guys still hear me?
You're good.
Sorry, I don't know. We're having some audio stuff on our side. Okay, so the great thing is these are all reversed in the same way. Now I'm trying to figure out how to get this to move forward without. Do you have any ideas to make that stop?
Okay, why don't we just come out of presentation mode? Sorry, of the two of us, I apologize. I'm usually the more tech savvy. Let's see here. Let's do take two here. Surround Zoom. Okay, let's try this. Okay, we're just going to do it in regular PowerPoint mode. How's that? That seem okay?
Yep, that's totally fine.
All right. My apologies. Go ahead.
Okay, good heavens.
Don't touch the mouse. Just press the down button.
Okay, So regardless of the opioid that somebody has overdosed on, naloxone is still effective. So it doesn't matter what medication or what substance they've been using. If an opiate is involved, naloxone is your answer in an overdose situation. So the question is, what does an opioid overdose look like? And it's really interesting because when we teach this in the community, we talk about certain things for people to look for and other things I actually try not to burden them with. You guys obviously have a better understanding of this. And so obviously the person is unresponsive. They'll have slow breathing, shallow breathing. They may be dusky around the fingertips or around the mouth. You can note small pupils. Obviously, there's a little issue there if the patient also has methamphetamines on board, because then the pupils aren't as reliable. But it's that unresponsive, poorly breathing. And how we teach it to law enforcement is basically, you're concerned this person is dead. That is the time you go for naloxone, regardless of what the situation is at that time. So these are the things that we're asking people to look for in how to diagnose or how to suspect an overdose. And then other things that suggest an overdose is truly some history. You know, the bystander or friends may tell you that there were substances involved. You may see paraphernalia at the scene, either pills or sharps. It's hard to say, but any of those could obviously be on scene. So you want to be careful with potential exposure. But we've also noted that patients will come in with fentanyl patches, a number of them on their bodies. And so you can even look for something like that.
So again, and you guys all probably know this, we truly just recycled one of our naloxone training PowerPoint slide decks for this. Really, unfortunately, naloxone will only reverse an opioid overdose. However, if it's a mixed drug intoxication, opioids are actually the most depressant on the respirations of any drug class. So if somebody takes some Xanax and drinks and uses opioids, they may not stop breathing as a result of simply the benzo and the alcohol, but you add in the opiate and the opiate pushes them above the threshold to stop breathing. It pushes them into overdose. So even if you think this person probably just drank too much, it is not unreasonable to give a dose. And truly, if they're unresponsive, there is absolutely no downside, because if they wake up, you just saved their life. So when we teach to law enforcement, they often know people in the community, and they'll say, for example, well, we know Bill, he has alcohol use disorder. We're not going to give him Narcan. The answer is absolutely give it. It might be the first time that he's using an opiate. In fact, actually, right after I taught one of our local law enforcement agencies about how to use naloxone, they actually got called on scene to somebody who was unresponsive, and they were like, we know her drug is alcohol. It turns out it was her first day trying heroin, and the paramedics arrived, gave her Narcan, she woke up and got transported. It was a mixed drug ingestion. So all of that in sum, if there was an opiate on board, it is important to give naloxone in a mixed drug ingestion, because you can still wake the person up enough that they'll begin breathing on their own. Now, we're talking a lot when we educate about nasal naloxone. There are many different formulations, right? In the ER, we have the luxury of starting an IV. We can give it IM. So the personal protection piece I'm going to talk about is in regards mostly to the nasal, but obviously if you're giving an injectable version of the naloxone, then you would want to make sure to protect yourself from any potential sharp exposure. So bottom line, you're responding to a medical emergency, take whatever personal precaution steps you need to. Gloves are great. People can vomit as they recover from an overdose, so eye protection is ideal if you have it. And then I think a mask is probably not a bad idea as well, just because you don't know if that person might be sick or infectious. The COVID, good heavens, COVID on the brain. The naloxone nasal spray does not have a needle, so you can basically use it without worrying about a sharp. And then the other thing, as I mentioned, as people are recovering from an overdose, they may go into withdrawal, which we'll talk about in detail. So you want to roll them away from you into the recovery position. If you're in an ER or like in the hospital, it's just kind of, you might be able to set them up and give them like an emesis basin. But we're talking about you're kind of walking down the street and someone's unresponsive, laying flat on their back, give them a dose. And if it doesn't look like they have any evidence of a neck injury, then you could roll them over gently into the recovery position, which is where they're on their side, so they vomit to the side rather than aspirate. When should you give naloxone? The answer is if someone's unresponsive or not breathing well, and you think there is any possibility there could be an opioid on board. I was working in the ER yesterday, and we had a guy come in who was really sleepy, and I thought it was respiratory depression from hypercapnia, from obstructive sleep apnea. And ultimately, we ended up giving him a dose of naloxone just because if it could have been an opioid that was involved, it potentially could have helped. So as a first responder, it's really anytime someone is unresponsive. It's a little more nuanced when you're in a medical setting, but I think the focus here is more on kind of us as first responders. So the next question is, when should you not give naloxone? And the question came up when I was putting together training for police many years ago. What if someone's allergic? Well, turns out I searched PubMed for, I think, what's that, almost 50 years. There's been 0 reported cases ever of an allergy to naloxone. The other thing is don't forget, if they're, forgive me for being blunt, dying of an overdose, an allergic reaction doesn't really matter, right? You have to reverse the overdose, and then we can figure out the epi, the steroids, whatever else on the backside to be able to treat the allergic reaction. So as best I can tell, it's never been reported that someone is truly allergic to naloxone. But if they were, like they had a medical alert bracelet, just give the naloxone if they're having an overdose, and we can always treat an allergic reaction either in the pre-hospital setting or when they get to the hospital. So bottom line, don't hold back if you're worried they could be allergic. The other thing is in people who are dependent on opioids. Let's take a minute, right? Dependence is when you use opioids regularly. When my dad was a cancer patient, he was on methadone and Norco. He was dependent on opioids. He was never addicted. He never crushed his pills, never snorted his pills. He never used too many pills, but he was dependent. So we're talking about opiate dependence. So in someone who's opiate dependent, when you give them a dose of naloxone, you will cause withdrawal. When we give it in the ER IV, we try to do a really low dose so we don't make them really badly withdraw. I mean, people literally will sit bolt upright. They feel so bad. And with the nasal spray, it comes on a little slower and it's a little gentler. So the withdrawal does not seem to be as bad. So basically, you can look for these symptoms in someone who's dependent on opioids that you basically induced withdrawal. So again, you guys all know these symptoms of opiate withdrawal: GI symptoms, nausea, vomiting, diarrhea, piloerection, diaphoresis, yawning, sneezing, crying, lacrimation, and then also just kind of anxiety and irritability. Once again, and I'll just briefly say this here, if you're worried about them going into withdrawal, save their life. We'll figure out the withdrawal after their life has been saved. And we can talk about giving Suboxone products or buprenorphine after withdrawal if we have time. If you don't have any opiates in your system, naloxone does absolutely nothing. I mean, when we do trainings, we both end up nauseated. We end up giving ourselves so many doses of Narcan to show people that it doesn't actually cause any damage. I mean, I'll take a dose right now. It's something that as medical students, obviously you guys are very aware of, but when we're teaching to the public, people are really worried. They're like, am I going to cause a heart attack? Am I going to cause a stroke? So we'll often give it to ourselves to show that it is essentially functionless if you give it to someone who does not have an opioid in their system.
And so how the Narcan nasal spray works, because that's the easiest one to have in the community. When we were putting this together for law enforcement, we had the option of putting together packets with the injectable. And truly on an overdose scene, pulling together and putting together an injectable and drawing it up and all of that is just too much, I think. And so when the nasal spray came out, that's when we really were able to put it in a community distribution. And so it comes in a box like this. We use our expired Narcan in training. So this is an expired dose, and we'll talk about that in a second. But it comes in a box, and if you open it, inside the box are 2 doses, okay? You've got the instructions here, which this is your instructions. You don't need to read them before using it. And then you've got your 2 doses inside, okay? And we'll go through that. But truly, so if you suspect that someone's had an opiate overdose, and if you're wrong, to Casey's point, if they're having a heart attack or stroke or whatever, and you've given Narcan, they're still having a heart attack or a stroke or whatever it is, that's why we call 911. Truly. First responders have additional Narcan, and they're also able to transport the patient or get them to a higher level of care. So what we tell when we were teaching the community, call 911, grab your Narcan, get ready to save a life and protect the patient until EMS arrives. That's what you would do if the person's having a heart attack anyway, right? Okay, so you take one of your packets here and you literally, there's another instruction thing. Oops, sorry. And here's your dose. Okay. One finger on each side. Okay. As you can see on the top. Closer. Yeah. One finger on each side, thumb on the plunger, and push. End of story. Like that's really all it takes to give a dose of Narcan. And when you're giving it to a person, and are you?
Yes. Feel free to borrow my nose here.
Okay. So literally, fingers on the two side, thumb on the bottom. You put it in the person's nose until your fingers touch the outside of their nose, right? Push the button. And that's it. Okay. Now, people ask all the time, what if I give it to somebody and they're sitting upright? It gets absorbed through the mucosa in the nose. And so it will still work, whether they're laying down, whether they're upright, slumped over, it doesn't matter.
Sometimes when people come to the ER for a private vehicle drop off, we'll see the person kind of constricted like this. And I mean, you can literally just kind of get your hand in there to give it to them. You can really get it in any position.
Yeah. So really important. And what we teach is you give the first dose, you watch for a response, and after about 2 minutes, if you're not noting a significant improvement, give a second dose. And that goes back to the whole fentanyl issue, and that even though this is a 4 milligram dose and our big dose IV is 2 milligrams, when it's absorbed through the nasal mucosa, it's slower and it's more kind of a gentle reversal. So you're going to need more, most likely. Some people will wake up with 4, and that's awesome. Many require a second dose. So after about 2 minutes, we recommend the second dose, but I certainly wouldn't, grab your watch because it's usually a pretty stressful situation. So if they don't seem like you're coming around pretty quickly, go ahead with that second dose while help is arriving. Thank you. Okay, so as mentioned, how does it work? Where the opioid is binding to that receptor, the naloxone literally just pulls it off, binds to it, and blocks any further activity. And that's how Casey was mentioning about the withdrawal that can happen if someone's dependent. And because this is a nasal spray, there's no sharps. Don't even think about, what you have to do to have a clean location to administer like you would if you were going to do an injection, where you'd want to clean the skin. Not relevant here, but we do get asked that. So we want to make sure that people are aware. And then disposal is literally in the trash. We've taught at the schools and with law enforcement, they can put it back in the packaging, report it back to their office, but there's really nothing that could damage anything or anyone. People say out of the reach of children, that's on the package insert, but there's really nothing that this can do. I wouldn't want my kids swallowing it, I guess. I don't know.
We'll share these slides with Michael if he wants to distribute them. We do have a training video that we did with our hospital that you can either watch or share with patients or share with family members. I mean, I think we're looking at naloxone right now in 2022 as a fire extinguisher, right? We're responsible homeowners. You bet we have fire extinguishers. By the same token, neither one of us has an opioid use disorder. We still carry Narcan. So we get asked all the time. Like yesterday I got asked, some members of the cafeteria staff at our hospital wanted to have naloxone at home just in case.
Yep. So
if you want to share this with anyone that you want to for training purposes, it's a video.
And the training videos are available both in English and Spanish, and they run about 6 minutes. And we did a Narcan training and distribution in the community. We've done a bunch of them, and we literally have it playing on loop. People walk in, they watch it 1 or 2 times. When they feel they're comfortable with it, they come get a box of Narcan and ask any remaining questions. So it's really fast and easy for people to absorb the information.
Yeah. So, just a couple of tips as a first responder. We're focusing on this as kind of the rescue out of hospital, but we can certainly talk more about the nuances of naloxone dosing inside the hospital. But I mean, imagine if you're coming up on scene and you see someone that's unresponsive. You have to remember to take care of yourself as a responder. So unfortunately, injection drug use is very common. We want to make sure that you're not the victim of a needle stick. The last thing we need is 2 victims, even though that's a relatively minor injury. So we see it sometimes in the emergency department after an overdose. Somebody comes in, we move them from the EMS gurney to the ER gurney, and we worry about what's in their pockets. Additionally, if you're responding to an overdose in the, in the community, we really want to make sure that 911 gets activated. Let's say you're wrong and it's, a hemorrhagic stroke, they need to go to the hospital. Or let's say it's like a methadone overdose and they're going to be having opiates in their system for like 24 to 48 hours. They might need to be admitted for an naloxone drip. So really anyone who gets a dose of naloxone needs to go to the hospital. And, if they decide to AMA with the paramedics, that's, a discussion between the paramedic and the patient. But as a community responder, I mean, we would do the same. I can't, even I'm an ER doc, but I can't do anything on the sidewalk. I need EMS there. The other thing, as we mentioned, is when you give someone a dose of naloxone and they are dependent on opioids, you will cause withdrawal. And that's okay. You just saved their life. Now, what's interesting is actually we can also give buprenorphine afterwards. I did this in the ER last week. I had a patient who could not tolerate the withdrawal needed to start on buprenorphine. So he came into the ER. I gave him 1 milligram of IV naloxone. I made him withdraw. And then 5 minutes later, I started buprenorphine and was able to kind of rapid induce him on buprenorphine. So our paramedics are hopefully in the next year going to start, I see rep loading because this was her baby. Hopefully our paramedics will very shortly be able to, in the field, offer people buprenorphine to palliate the withdrawal of a naloxone rescue. They're doing it in Oakland. They're doing it on, I can't remember which,
Camden, New Jersey.
Camden, New Jersey. So actually, there is even a solution that if you cause withdrawal from naloxone, you can actually treat their withdrawal with buprenorphine. And I have one more slide on that that's going to be at the very end. And we wanted to add a couple of pieces on fentanyl, just because fentanyl changes the game a little bit with naloxone.
Yeah, so truly, this is just, you're going to need more. As you guys all know, fentanyl is more potent, it's synthetic, it's dirt cheap and easy to make and to put into any of the counterfeit drug supply. It's all over our meth, all over our cannabis. I mean, fentanyl's in everything here. And so even when my patients are meaning, their intent is only to use methamphetamines, they don't get that choice in my drug supply. And so every patient that has the possibility of having an exposure to an illicit substance, you need to consider needs naloxone, or their friends do, more importantly. But even, I mean, Casey and I were driving home from an event and there was someone slumped over by the side of the road. With the drug supply that we have here, that is presumed fentanyl, or at least another opiate overdose, until proven otherwise. So just be aware, I don't know how prevalent fentanyl is in each of your communities, but here it's everything. So I know you guys are familiar with kind of the nuances of it. What's really interesting about it is we're seeing, and this goes more for buprenorphine, but that when people are using fentanyl, 10, 8, 12, 15 times a day, it builds up in their fat stores. And so it's crazy how long it can take for someone to completely have it out of their system. And so again, you're back to the importance of having naloxone available. And it's in pressed pills, it's in powder form, it's in what looks like Lucky Charms, it's rainbow colored, it's all over the place here. Fentanyl looks the same as every other opioid, but it is more potent. So those 2 doses and 911 for the next dose. Actually, our teachers were putting it on their lanyards. We're literally taking the package and putting a hole in it and putting it on the lanyards of our administrators at school. So the first person on scene has Narcan, the second one, it has another dose with them, instead of waiting until we get to the office. That was actually before the most recent fatality in Los Angeles. Yeah, so just back to the point of fentanyl and that you would need any additional dosing, but what I really want to get to is this.
One other thing before we wrap up here, and Michael, I don't know how much time you want us to take. I want to be respectful. I heard there was another speaker, but naloxone does have an expiration date, and once it's expired, you can still use it as a community responder. So it drops in efficacy about 5% per year. So let's say, for example, you look at the box and it's a year old, probably still works. I actually keep some of the expired Narcan in my car. I have like 6 doses just because there's nothing else to do with it. And if I need to respond, I know it's not as effective, so I'm just going to carry more. So that's another thing we message to people. Michael did mention I got to make a shameless plug. I do have an addiction medicine podcast. I did highlight the episode. I did one on giving buprenorphine after Naloxone Rescue. Poor Michael was working with us right when I was just starting my podcast, so he had to listen to all the bad episodes. So it's on Apple Podcasts, it's on Spotify, and I think here we'll stop. These are our emails. Please reach out if you have questions about addiction medicine, emergency medicine, harm reduction, working at syringe exchanges. We're just grateful for the time to be able to talk about something that we spend a lot of time working on.
Well, thank you both, Dr. Close and Dr. Grover. By the way, if you all have any questions, you can go ahead and ask those in the chat, or you can unmute yourselves to ask as well. You two were the last speakers. So, don't feel rushed or anything. And also just really fast before everyone logs off, there's going to be a QR code for you all to scan. So that way we can take down your names and emails. So we can send out the certification. But yeah, so please feel free to ask any questions. I guess I can start it off with, you say dosage. When you're using the package, is it only, sorry, maybe you already said it as one, I missed it. What's the, how many doses come in one nasal spray?
So the nasal spray comes in a blister pack, and each blister pack each one of these is 4 milligrams, and the box contains 2 doses. So from a community responder standpoint, if you have a box, you have 2 doses of 4 milligrams. From kind of the nuances of dosing, if any of you are working in the emergency department, or like you're on a medicine rotation and need to respond to someone who gets too much opioids inpatient, the dosing IV and IM is different. So IV, I give like 0.4 because it's so much more rapid and potent. And I really don't want to make my people withdraw. It's just mean. The guy that I told you about that I gave naloxone to electively, I chose 1 milligram because I wanted to get all of the fentanyl in his opiate receptors displaced. So I had room to then give him some buprenorphine. For IM, usually it's like 2 to 4 milligrams. IM's more like kind of like a Hail Mary, like, oh my gosh, we don't have time to get IV access. Let's just get them awake and then we'll deal with it. But when you have an IV and you can almost kind of like titrate, like let's give 0.2, see if we can just get them breathing. Let's keep them comfortable. And patients are deathly afraid of Narcan because they don't want to withdraw. And so being respectful of that. And again, the nasal spray is such a gentler reversal than the IV. It's really a lot nicer for patients. And a lot of times patients don't want to receive a prescription because of stigma, or they're like, oh, that's not going to happen to me. A lot of the messaging we do for patients now is like, hey, do you need some Narcan? They're like, no, not for me. Like, well, gosh, fentanyl's out there. Maybe you could save someone else's life. So that's kind of how we've been messaging it to people. That wasn't in response to dosing, but that's how my brain works. I apologize.
I think it was a great explanation. Thank you. Did anyone else have any questions or comments? Don't be afraid to speak up.
Oh, if I may add, a lot of patients will reference an allergy to naloxone. This is mainly my patients in the street clinic that are not excited about having buprenorphine with naloxone in the combo product, and they feel better with the buprenorphine mono product. As Casey mentioned, a true allergy is really not the last time we looked, is not documented. That said, many patients in that reference are referring to having withdrawal when they get naloxone. So I think as a provider, mentioning that and acknowledging that, oh, I know you must have felt terrible when you got Narcan, because they put you into withdrawal, that's different than an allergy. Patient still feels awful, but it's different. So I think just being aware of that as the provider and having that knowledge base to share with the patient and acknowledge their symptom is really nice and really helpful. And it also helps break down the kind of the stigma of them believing that maybe you don't know what they're going through, you don't really understand, and showing that insight, I think, is really it helps to build a lot of trust in the physician-patient relationship.
Understood. I guess I'll ask one more question because I can ask a question for Dave. So, but if anyone else has a question, please feel free to drop it into the chat or unmute yourselves. Actually, it was kind of pertaining to a question we just got. So from Grace, they said, have you had any lawsuit case regarding treatment of the patients?
So there's a couple of things. So you know, if you're talking about from if I'm wearing my doctor hat and I'm in the emergency department, you know, I'm not aware of really anything that would be putting me at legal risk for giving me a dose of naloxone unless I'm using it kind of negligently or maliciously. There are plenty of stories of years before where people would give Narcan to people with addiction to get them clean, ready for treatment, which was really just being mean to induce withdrawal to make them miserable. That I could be liable for. But if, you know, somebody's coming in and they're truly having an overdose and I induce withdrawal, I don't think I'm at any malpractice risk because they were in an overdose in the first place. Additionally, now we can get them on bupe right away and we make them feel better. You know, additionally, you know, let's say I gave a dose of naloxone and it was a stroke. I'm going to be working them up for a stroke anyways. If they don't respond to the naloxone in 30 seconds to a minute, I'm going to move on and pursue other diagnoses. But I think what Reb wants to talk about is the first responder lawsuit part.
So we actually made tip cards in both English and Spanish for our community to talk about the Good Samaritan Law. So if, you know, you're on the street and you're responding to an overdose, there's a couple of components to it. If you're acting in good faith, I am worried about this person, I'm going to give them Narcan to try to save their life, you are protected by the Good Samaritan Law. In addition, and I tell this specifically to our students, to our high school and college students, that if you're at a party and everybody's doing just loads of drugs and somebody overdoses and you're on scene and you call for help, you're also protected by the law. Yes, there's lots of drugs there. And yes, it's probably some behaviors that aren't necessarily legal, but you are not going to be in trouble with the law for calling on behalf of that person who's dying. The point is to protect people and to keep them alive. And so the Good Samaritan Law, and look it up in your state, but the Good Samaritan Law is there to protect people when they are trying to save a life and to help people.
And just to clarify, you know, both of us are physicians. If we're not at work, the Good Samaritan Law applies. So we're not held liable because we have medical training. You know, it's basically the standard of care on the sidewalk is the sidewalk, regardless of who it is. So you don't have to worry that you're a medical student and you have special knowledge and therefore you could be liable.
No, it looks like Florida has the Good Samaritan Law as well. Awesome.
Well, this was super awesome. I don't know if there are any more questions. Hey, Dr. Close. Hey, Dr. Grover.
Hi, nice to see you.
Good to see you too. For everyone who's on here, they were a couple of my mentors my third year, towards the end of my third year. And I rotated with both of them doing addiction medicine and opiate overdose. So I'm super grateful that you guys were able to join, and thank you, Rico. Rico's leading our Community and Public Health Action Committee and has been doing a great job with National Primary Care Week, so I want to give him a shout out. I'm going to drop in the chat. So I'm going to send it to everyone, not just to one person. Like we talked about, since everyone participated in the training, we're going to do a little certificate system, and I'm going to also share my screen with a QR code for everyone who's on the live stream and can't see our chat. This is also being live streamed, and I haven't gone to see how many people are listening on there, but I heard it was a good little chunk. The certificates will take us a little bit of time, probably at least a week or two to get those to you. But if you fill them out, we'll be sure to send those to you. And that's something you can put on resumes and on ERAS, as I am going through right now, which is super great. Definitely look at Dr. Grover's podcast. I don't know what he was talking about. It was good from episode 1. It's great. It's super good. But yeah, unless there are any more questions, or if either of you two or Dr. Bruno, who I just saw is still here, have any questions or any last comments, I think we can let everyone go.
Well, before we let everyone off, I do want to say thank you again to, Dr. Close and Dr. Grover and Dr. Bruno as well. And National Primary Care Week is just getting started. So, and then also we're also working on getting distribution of Narcan. Hopefully we'll give you the resources so that you can get it to you all and carry it now that we have the information we need. But tomorrow we do have a repro session tomorrow on the restrictions of repro, and it should be a good one. So join us again tomorrow, and thank you all again for joining and staying with